Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's session is care of CLHIV post-ART initiation, and the speaker is Dr. Kalpana Datta ma'am. Dr. Kalpana Datta ma'am is the Program Director for pCoE MCH Kolkata. We welcome you ma'am for today's session and request you to start the session.
And thank you, Dr. Sheta, for your kind introduction. And good afternoon to everyone. And I would request all the participants, please spread this message and please ask your colleagues and friends whenever you have any meeting and that please join the RDLS and you just, it should be, interactive. You will go on asking questions and all. There should not be like, I'm directing lecture, I'm giving the lecture and your people are listening and all. So it won't be very helpful. If there's an interactive session, that will be more helpful. So if you have any queries, please put on writing on the chat box your queries and I'll address at the end. So today's topic is post-ART initiation care. And there's a very important aspects of any disease. So when you diagnose the case and you HIV positivity and we know the test and treat policy, you started ART. But the post-ART care, if it's not proper, there's everything will be in the drain. So it's very important to know what are the things to be seen and how to do the post-ART care. So what are the components of this session? Components and objectives of post-ART care. So for, in every way, in every aspects of human life, or similarly in ART center also, whenever we do something, we have something in our mind that these are the things to be done. Similarly, here also we have some components, some objectives for post-ART care. So what are the things to be done? You make a list in our brain, make it in a priority basis, arrange it, and accordingly you act. So the next is the very important part of monitoring after ART initiation and child living with HIV. If you won't monitor, there may be lots of issues and that is not addressed. And then there is no point in giving the ART continuation. Then ARV adverse effects and its management. If there isn't any adverse effect, we are not addressing these things. We're not asking. There may be confusion. It is because of the disease itself, not because of the drug side effect. They might think the drug is not working or some why is there. So how to differentiate the adverse drug effects or why and disease itself can cause sometimes some diseases which may mimic the drug side effects, and how to manage these things to be discussed very clearly to the parents and caregivers. Then drug substitutions. Sometimes you might have to substitute some drug only because of the failure, because of the drug interactions, because of the organ damage, and there are lots of issues that should be addressed. So objective of post-ART care, to ensure the safety of CLHIV on ART. So how far the ART is safe? That means the minimum side effect and maximum benefits should be assured. To optimize the benefits of ART, so when you will start, when you will choose, what are the drug interaction, what is the why, all those things to be taken care of while optimizing the benefits. To monitor the response to ART, that's very important. Babies, another few criteria to see whether baby is responding with the ART or not. Early detection of treatment failure and comorbidities to be addressed. So it is very important. If you monitor, you will realize all those components will be automatically very obvious and you can address all of them. So what happens to the child in the first 6 months of therapy? That's very important. What do you expect when you start something? I think all of you must be the medical officers, few are their counselors and all, but medical officers who have gone through the rigorous training during course, you know, the pharmacodynamics, pharmacokinetics, the drugs. So I say whenever you prescribe any drug, you should have in your mind what this drug is going to do inside the body and how the body will react with this drug. These things are very important. So whenever you prescribe any drug, not only ART, even if you prescribe the paracetamol, how it will be go to the target site. So you have to know the mechanism of taking route of absorption, then it will go to the blood, it will go to the target site, it will act in that way. So this is a very important issue for the pharmacodynamic, a bit about the pharmacodynamics and pharmacokinetics, whatever the drugs you are using or prescribing through your own hand. This is very important. So what do you expect indirectly? What do you expect? You will expect the baby will have a viral suppression because you are using antiretroviral drug that will decrease the viral load in the body, and we will see by the viral load estimation. So you expect there will be a viral suppression in first 6 months. And of course, the root cause is a high viral load. So if the viral suppression will be there, then there will be clinical and immunological improvement. So what are the criteria to know the babies are clinically improved? And of course, in immunological improvement, we always see the CD4. The improvement in the quality of life and decrease in morbidity and mortality. So again, it's very important. If there's a clinical improvement, then the feeling of well-beingness. And if you know that if there's a well-beingness is there, then the good mental health will be there. And then the quality of life will be quite good and it will be improved. And of course, when there's a viral suppression, there's a clinical improvement, there's an immunological improvement, automatically there will be morbidity will be decreased, and of course the mortality too. Certain opportunistic infection may appear. So what are the other possibilities you might think in the first 6 months? Certain opportunistic infections that may appear even in treatment. Immune reconstitution inflammatory syndromes may develop. Early adverse drug reactions such as drug hypersensitivity may occur. So while examining the baby to see whether baby is having a clinical improvement or not, you have to keep in mind whether, because you know the tuberculosis, like one of the important opportunistic infections is tuberculosis. Tuberculosis can happen in any person in any time, whether virally suppressed or not, whether immunologically suppressed or not, whether it's immunocompetent or immunosuppressed. So it's very important to rule out in each and every visit about the tuberculosis infection. Of course, other common infections on that particular time, and any geographical distribution of any disease which is there. Like you must be knowing now, we're going ahead of eradication of the non-communicable disease, and especially the neglected tropical disease like Kala-Jar with HIV, especially in adult and all. So any child who is having hepatosplenomegaly and you are treating for the HIV and baby is not regressing back, the liver spleen still high, still enlarged, then you must think whether there's any opportunistic infections there or not, like tuberculosis and collagen and all, and you have to send the appropriate investigations. Next is the immune reconstitution inflammatory syndrome. What happens? Body is immunosuppressed. So body does not have a power to fight against the infection which is there, means against the HIV viral infections. As soon as you will give the antiretroviral therapy, there's an increase in the immunity. So when there is immune reconstitution, means that whatever the immune was suppressed, that is reconstituted, and there's an increase in immunity. Now the body has a power to fight against the infection. So there will be a fight between the virus and the body immunity. So ultimately there will be some outcome. And what is that? There may be some clinical symptoms, and that is called the immune reconstitution inflammatory syndrome. And you say the syndrome means a conglomeration of many symptoms. So you might get many type of disease symptoms and signs after the initiation of ART, and they may not be due to the opportunistic infection or the failure. Then early adverse drug reactions such as drug hypersensitivity may occur, and that should be very important to notice. Like I'll say one scenario. One of my patient came in my OPD, 6 years old female child, one avacavir based regime, and she was just sweating in my OPD. I said, why? She was a bit lethargic. The father said, since morning baby is having fever. And I saw the baby was sweating and a bit depressed, because we are trained to see the sick child and we know who was sick and who is not sick by trials. So I immediately admitted the patient and I sent it to my ward, and baby gradually went to the shock, and it is a avacavir hypersensitivity. So immediately there is a management, and all my residents are given the treatment of shock and all, and baby improved. So that is very important in a busy OPD, which baby to be looked first. So it is very important to do the triage. The triage means quick screening. You have to you have to give the priority, which patient to be tackled first. And that you will learn by your day-to-day experience. This is not a one-time job, because today only you sat in the OPD and you realize who is sick or not. No, it is a on-time learning experience, and the patients still give us the learning. So you'll know which baby is sick, which is very sick, which is stable. And according to priority, you have to give the treatment. So it's very important to look up, and you have to be aware of the drugs and their side effects. So adverse drug reactions are there or not. You have to voluntarily ask some questions, because they might ignore the diarrhea, might ignore the fever. They might think nowadays everyone is having respiratory tract infection. That's why he is having fever. It may be due to avacavir drug hypersensitivity. So voluntarily, that is called is to say leading questions. Always you ask some question to the parents as a leading question. Do you have this, and show that you will can early identify the drug reactions and can take care. So objectives and monitoring. Response to therapy. The first response of the therapy of any treatment in children is you will see the baby is well looking, playful. He is not lethargic or lying on excessive sleep. So see whether this baby is active, playful or not. Second, that is the objective criteria. You may think a baby is active and some other person may think baby is not that active. So this is an object. But if you have a object like measurable criteria is a weight. So very important to see the weight. And each and every visit you just see the weight, and this that to be kept in mind, because might have come patient has come in December with a full of sweaters and jackets and all, and you took the weight. Now he has come with the summer has started already started, so babies might have put on only a t-shirt. So if you do the different weight, and you might think there's a weight loss. So very important to see what stage and where you are taking the weight, which machine you are using, machine is correct, giving the correct weight or not, and the minimum clothing during the weighing is very important. So weight criteria is very important criteria to know baby is improving, and that to be measured very accurately. Sometimes you might need even a busy OPD is not possible, but it is better to have a 3 reading and take the average of 3, or the which is similar, having two reading is similar, that to be noted. Then you do the T staging. As you've already started the antiretroviral therapy, you see the clinical staging, what are the criteria, stage 1, stage 2, stage 3, 4, according to the WHO criteria, and you do the staging and you write it. Please don't forget to write the staging. It's very important, because sometimes we see there's not mentioned the green card, it's not mentioned the white card. So always mention the, it hardly takes few minutes. So always write the weight and T staging. Second is the drug adherence. It's very important. In pediatrics, it's so important, because sometimes we do get the patients SASIP also. I got one patient who took the drug, and every time he used to vomit, because it's a bitter taste. The maximum drugs which are preparation are there, or especially the syrups, are very bitter in taste. Even if you take, you will vomit. It's so bitter. So always ask if there are any vomiting after the taking the drug, 10 to 15 minutes. So if it's more than 30 minutes, okay, it has gone to the stomach and it might have absorbed. But within 30 minutes, if there's any vomiting, that means that drug was not absorbed in the gut. You have to repeat it. So very important, not only the pill count, not only the asking whether taking medicine or not, but whether baby has vomited or not, that too very important. Then, of course, if you see the CD4 count, there will be increase in CD4 count, and there's a fall in viral load that give a criteria that baby is taking the medicine. Then for the iris, again, you have to see the 4S screening. As I said, in each and every visit, you have to ask for the fever, cough of any duration, not gaining weight or losing weight, and history of contact of tuberculosis. In the last month, might have come without any history of contact, and this time might have a history of contact. So every time you must ask if is there any history of tuberculosis in the families and adults in the nearby, to whom he is having daily contact. So very important. And of course, that the fever and cough in HIV patient is said of any duration. But the doctor on the who is sitting on the ART, he has to apply his clinical skill, because every fever should not be screened for TB. Other there will be misuse of infrastructures and the HRs. Because now here in Kolkata, in West Bengal, we are having many respiratory tract infection. I think, and even in the eastern region also. Yesterday, I got message from the Odisha. I got message from Delhi also. So different type of ERA infections, which is very common. Every year we do get from the December to February many ERA acute respiratory tract infections, and that is not because of tuberculosis. It is because of some viral infections. So you have to judge, because in case of viral infection, you have a running nose, you have a conjunctivitis, red eyes, you might have a diarrhea. So all these things may be due to the viral infection. Tuberculosis won't cause this type of symptoms, conjunctivitis or running nose and all. So you have to use your clinical skill to determine whether you will go for the screen for TB or not. But by protocol, fever and cough for any duration, or not gaining weight or losing weight. But as I said already, mind it while taking the weight, whether you are taken in the proper scaling and proper weighing is done. And history of contact, you always go for the TB screening. Then close clinical monitoring in any opportunistic infection the first 6 months. So you have to look for any GI infections, any respiratory infections, any skin infections, and of course, when baby is kid and developmental milestones to be seen for the neurological infections. Then adverse drug reactions. This is very important. And you must know what are the drugs your baby is consuming and what side effects you may expect with these drugs. So you just see what are the drugs baby is taking. Not only the ART along with the maybe ATD or any other antidiarrheal drugs or any ionist prophylaxis or any other drugs which baby is consuming, you must see all the drugs. As you are sitting in ART and you will take care of the only ART drugs and you forget the others. No, you have to take it. What are the drugs the baby is taking? And what are the possible side effects could happen with these drugs? And see if the baby is having this type of drug reactions or not. And of course, suppose the patient is having a jaundice, rash, and you are suspecting this because of the drug, then always see the other symptoms. Or it may be due to, suppose the baby is not taking abacavir, some other drugs baby is taking, and there's a high fever, jaundice, and then you might think it is acute viral hepatitis. So both the things, and if you're in confusion, go for investigation. Think for the drug reactions and go for the other differential diagnosis, and always take care of that. Then if possible, you can do the lab monitoring for drug toxicities and their comorbid infections. Then treatment failure, viral load monitoring at 6 months and then thereafter. So we'll go on doing the viral load monitoring 12 months and yearly thereafter, and CD4 monitoring 6 monthly. And when it is normal, more than 350 but 2 reading, then we will go for the only yearly monitoring of viral load. So it's not moving. Slide is not moving. Okay. Okay. So effect of ART. After ART initiation, if there's a high viral load, if you know from the very beginning, the babies have a load is viral load. Otherwise, it's difficult to judge whether there is a drop is there or not, because we don't see before starting ART. So viral load might not be there when it's a naive patient. But expect there will be a drop of viral load with the treatment, non-adherence treatment, treatment failure, there will be rise. So even after 6 months, there's viral load is quite high as it was there, and you expect there will be a drop, but it's not there. So there are maybe non-adherence or maybe treatment failure. Before diagnosing this is a case of treatment failure, please inquire about the non-adherence. That is the main issue in pediatrics. Then CD4 count. Again, you know, as there's a ART will go act and there will be viral suppression, so there will be immunity will increase, and that will be reflected by high rise of CD4 count. But if it's still there's a CD4 low and it is further going down, you must suspect whether there's baby is not taking drug, or sometimes something might happen or it's not responding. So it may be treatment failure. Then start immunity as it's reflected by the increased CD4 count. So starts to recover. So there previously you might have seen there are many recurrent infections in HIV patient. As soon as we started ART, baby is feeling well, getting wet and all, and there is a gradually decrease in the incidence of opportunistic infections. But in spite of having ART therapy, and then the patient has taken for 6 months, there's no improvement. Baby is still lethargic, we're still feeling weak, and the lots of opportunistic infections. You might think there is either a treatment failure or there's a non-adherence. Now, what are the clinical examination will do? In each and every visit, you must examine, take the history, proper history. Few things very important. First, baby is playful or not, active or not, fever is there or not, diarrhea is there, how is the appetite, whether baby is going weight. These are the few things you must ask, and then check the thorough. You just run your eyes from head to toe, and just palpate from head to toe. You'll get the things. So it is very important to examine from head to toe. The clinical evaluation or overall well-being is very important criteria. And of course, if mother complains or you can identify any new clinical event, that to be noted, and you think why it could, what is the possibilities, so whether it's a drug induced or it's a opportunistic infections. Then for screening, as I already said, treatment adherence is very important. Not only the pill count. Pill count is won't serve any purpose, because maximum cases we see the pill is a pill, according to the pill count is more than 90%, more than 95%, sometimes 100%. But when real scenario, if you ask the parents, and then baby will, you ask the baby also, you ask your school timing, you ask their the extracurricular activities timing, you ask them about the holidays, because the school timing, there may be routine is different in in holiday, the routine might be different. So at that time, the kids may take the drugs at different times, may vary, may forget. These things you have to give the leading questions to know the treatment adherence. Adverse drug reactions already discussed. The lab monitoring, ARB related toxicities, intercurrent illness, drug-drug interactions, other metabolic abnormalities. So what are the investigation must be very rational. Don't write LFT, RFT, lipid profile like this. Always what do you want and what do you, why do you want? This is very important. ARB related toxicities. So what drug baby is taking? If lopinavir, we go for the lipid profile. What are the lipid profiles you want to see? If baby is taking, the child is taking the tenofovir, whether you want to see the cardiac toxicity or demineralization of bone and all. So accordingly, you send the investigations. If you think of intercurrent illness, rationalize your investigation and write it. Otherwise, what will happen? It will take your time, and the lab lab will be exhausted with their HRs and infrastructure because of the huge load of investigations. But if it's rational, to the point investigation, they will also give the correct result. So very important to be send the investigation with the rational indication. Then, of course, always think of drug-drug interactions or any drug toxicities. Other metabolic abnormalities, sometimes we do see there are some metabolic changes due to some drugs, especially in tenofovir. In case of lopinavir, ritonavir, you might get the lipid profile in case of tenofovir, you have to see the any secondary renal damages there or not. For that, you have to see the metabolic sodium, potassium, calcium, phosphate in the blood. The immunological monitoring, that is reflected by CD4. So we'll do the CD4 testing, and of course, the viral load monitoring up to 6 months. So as I already said, growth, nutrition, development, for screening, clinical monitoring, treatment adherence, and calculate ARV dose as per weight, each and every visit. It's very important, the last part. We do forget about the proper dosing in each and every month, because, in the younger the age, the more variable in the weight. So it's very important to see the weight every visit and check the drug. There's no harm. You just take the chart and see whether the baby is taking the drug or not. Just now, yesterday only, I saw the baby was taking 2.5 tablet. Actually, it should have been 3 tablets of avacabit ale. That happens very quite often. So it's very important to check the weight. Don't forget, if you don't check the weight, you will, of course, then there will no checking over the dose per weight. So you have to take the weight. You have to see the dose as per the weight, and whether baby is consuming that. Because I've seen one case where the baby was, parents were asked to take the 3 tablets, avacabit, lamivudine, pediatric tablet, but it was not counseled and not emphasized so much. But and the mother was used to give the previous dose, that is 2.51, was giving for long. So this happens quite often in pediatric age group. It's very important to see. And if there's a loss of weight, you can decrease the dose. Other, there might be toxicity also. So developmental progress and developmental progress, again, if the younger is above 5 years, okay, everything is a motor. All the 4 milestones are achieved, means baby could gross motor, fine motor, speech, and socio-personal is already developed and go on developing. It's not that difficult if baby is more than 5 to 6 years. But in a younger age group, you always ask, the only one question is very important. Are there, you have any other kids other than this baby? If they said yes, then is she or he is growing as the other baby is growing? Or what the milestones, whatever the milestone baby has achieved is normal with the other siblings have achieved in that particular age. If they say yes, okay, that means baby is growing well. Provided that the other siblings are okay, not affected, or having a normal course of life. But if they say no, ye to piche pad gaya hai, is his or her delayed, is not achieving everything in the normal time. 1 year, baby could not sit, baby can't walk, baby is not speaking, baby cannot respond your call or by name. These things very common, few things, but you may realize that there's some problem in the developmental progress. That's very important. And at all, if there's any confusion, refer the child to the pediatrician. So record every visit. Weight linked, again linked. younger age group, you must record very important and every 3 months, because don't length is so much is not so variable. It doesn't change in a month time, and there's no need to record the length in every visit every month. But so you have to measure the length 3 monthly up to 2 years. Above 2 years, we say it is a height. So with babies less than 2 years, we'll take the length in an infantometer. And if baby is more than 2 years, then you can measure by the stadiometer if you have in your center. If you don't have a stadiometer, then there's a measuring tape. You can hang it from a state board and can measure the weight. And then it's very important. There's a graph in that white card. And everyone is having immunization card also. And always plot the graph. There's no point in taking the weight and length. If you don't put it, you won't realize whether the baby is growing normally with the parallel to the normal curve or faltering. So you have to plot it on the, it hardly takes 2 minutes. So you just take the weight, put on the chart and draw the line and see whether it is parallel to the normal graph or not. Weight for length can be checked from the reference table. So sometimes you might need, clinically you see baby is a thin, wasted, malnourished, then of course you have to calculate the weight for length or weight for height, that is called wasting. And there's a chart for the graph is available for that. You can put on the chart and see the weight for height or weight for length is low or normal. Then early identification in case of faltering. What are the importance of plotting this growth and length and see the weight for length and all? It is the early sign of failure. So it's very important to monitor because growth is the most sensitive criteria in younger age group. So intensify the assessment for HIV-related features. If you see there's a not gaining weight or there's a growth is faltering by seeing the curve, then you re-intensify, re-look your patient and thoroughly examine the patient. Screen for nutritional deficiencies. Because not only the protein and calorie who are deficient in nutrition, they'll be deficient in other micronutrients and vitamins and minerals also. So you have to look at the Bitot spot, cirrhosis, congenital cirrhosis, and angular stomatitis, chelosis, glossitis, and other signs of vitamin deficiency. There might be deficiency of vitamin D. There might be features of rickets, B-complex deficiency, gum bleeding, maybe vitamin C deficiency. So always look for that. You can just go on examine from head to toe. You'll get the signs of nutritional deficiencies. Then check for the chronic infections. Again, respiratory infections, cough, respiratory tract, lymph node enlargement, respiratory, if you count the respiratory rate, so any respiratory distress is there or not, GI infection. If you see the way constipation, diarrhea, pain abdomen, vomiting, abdominal distension, a few questions will suffice. Then urinary tract infection, that's very important. In older age group, you will get the typical symptoms of urinary tract infection like burning, micturition, increased frequency, pain during micturition, and but in younger age, you might not get anything, just unknown fever. So if there's a fever, don't think it may be because of HIV and all. It might be ART is working and viral suppression is there, but still baby is having fever. Then you, along with the screening for TB, you must rule out the urinary tract infection because it may be any without any other symptoms and signs. Baby can have fever with urinary tract infection. Then child with a growth faltering should be immediately referred to a pediatrician. If you have any query, anytime, refer the patient to the pediatrician. You see the graph, it is normal graph for boys. They're different. Up to 5 years, we follow the WHO chart, and 5 to 18 years, we have a IAP chart, Indian Academy of Pediatrics chart. And it is already plotted. You can see whether the baby's growth is curve is parallel to the curve seen. It should be either in above side of the green, then it's normal. If less than -2 and more than +2, then it is abnormal. Otherwise, 0 to 2, 0 to -2 is the normal range. You see it is growing. But what happens, you see, the curve gradually it is parallel to the red line or green line and suddenly started a bit low. Then you see the next curve, which is again down, again flattened. So when you see this is a baby, or suppose it is started flattening at 7 months, 6 to 8 months. That means when complementary feeding is started. That means after exclusive breastfeeding, baby was getting weight. As soon as the complementary feeding is started, at that time, there is a faltering of growth. That means complementary feeding was not appropriate. And you have to should have taken care of it at the very beginning at the 6 months to 7 months. And a patient might have come at 18 months and you will see there's a flattening of curve. That gives, even the layman can identify there is a faltering in the growth. These are the curves. You see that this, if you could get this type of curve, it is a growing well. The left hand side, in the case of middle, it is just started faltering because it flattened. And if you see in the third one, it is growing down. That's one losing weight. And then urgent assessment is needed. Why baby is losing weight in spite of giving the nutrition therapy? That might be it is not working, or maybe failure, or maybe opportunistic infections. Now, this is a chart for developmental milestones. You see what is the age of your kid, and you identify that age in months in the graph, and put a chart and draw a vertical line over there. And you see how much black bar has covered. So if it is already it is covered fully or more than at least 80%, that means those milestones should have been achieved. Suppose there's the red dot at 5. You see the 5th month, and the social smile, eyes follow the pen or pencil, any red object, eyes follow the red object, and holds head steadily. It should have been achieved by 5 months. If it's not there, that means delayed milestones. But rolls from back to stomach, you see, turns head sound to be a bell or rattle, that should be achieved, but it may be partially achieved because it whole bar, it has a big range of achievement. So this bar shows the range of achievement, and the initiation of bar is the starting, and the last end of the bar is that is the time period. And all individual, all children are different in their own aspect. So they may have a different range of achievement, but that range should have been within the normal stipulated time. That should, but if you have any confusion, you just refer to the pediatrician. Abnormal development is this, maybe due to HIV infection, maybe due to nutritional deficiency, maybe any other infection, some tuberculosis meningitis, sometimes other neuroinfections. So that very important. I'm not going detail with this developmental assessment because it's not possible for you to see in a detail, but at least gross motor and fine motor, language and social skill. Gross motor means head control, sitting with support, without support, then crawling and creeping, turning from prone to supine, supine to prone, then cruising with the furnitures. He can get up with the holding the furnitures, then walking 1-2 steps, then walking independently, then walking backward, sideward, then running, then jumping, then hopping, then skipping, and then the riding tricycles. All those are gross motor. Fine motors are like hand-eye movement, hand-to-hand transfer of the objects, hand-to-mouth coordination. Then there will be feasting, there will be release of feast. Then there will be a pincer grasp, means they will pinch up, they will pick up the things. Murmura and all, anything is there on the pup rice or any muri, what we say in Bengali, the muri, and in Hindi we say murmura. In English we say the pup rice. So if you give it in the plate, they will pick it up with the 2 fingers, and that is called pincer grasp, and that is developed in 9 to 12 months. They will see the pincer grasp developed or not, and you will just ask कि muri कुड़िए खाए, can baby वो मुरमुरा पकड़ के उठा के अपने आप ले सकता है? They will say yes. So these things are very simple questions you can ask to the parents, and you will realize they got fine motor is there or not. The language, of course, in the 3 months, they production sound, they start gradually they start laughing loudly with sound. Then they will say monosyllable ma ba words. Then 9 months they say bisyllable without meaning. 10 to 12 months they can say mama, baba, dada. Then they'll waves bye bye. Then they will say says bye bye. These are the common. And then of course they can say the sentences, pronoun, I, you. All those, all the stories. Social skill again, social smile. Baby will smiles at mother at 3 months, then he will realize at the 6 month, they strangers anxiety, they'll enjoy with the mirror. Then again 9 months, 12 months, 18 months, these are different social skills, and their bladder and bowel controls are also parts of the social skill development. But if you don't remember the normal one, please remember the abnormal one. That's very important. When you will send the patient to the pediatrician, that they're called red flag signs. What are those? Hold an object placed in the hand by 5 months if he has not achieved. Reach for objects by 6 months. Sit unsupported by 12 months. They should have been achieved by say 7 months, but still 12 months he is not able to stand with sit without any pillow and any support. Walks by 18 months or run by 2.5 years. So these are the 5 when baby couldn't do, you must send the child to the pediatrician. Signs of poor nutritional status. If you see from the distance, you see that only in this picture, It is shown only the whole body as if there's a bone and a skin. There's no fat, no muscle mass. So by visible, that is called visible severe wasting. And you see in the back of the child, it's like a baggy pen appearance. The loose fold of skin in the buttock. There's no pad of fat, no muscle mass. So these are the severe wasting, and it can clinically obvious. It's very obvious from the only by the examination. You don't have to measure anything. That is called clinical visible wasting. Then, of course, the oral thrust. It may be in the if you see sometimes we do forget to see the open mouth of the kids. We have seen because they always come in. If the younger babies, they'll come in the mother's lap. Oh, you'll ask the mother, "Baby is okay?" They'll say, "Okay." I don't. You forgot to see the mouth, but always examine the mouth. Make a habit to ask the mother to open the mouth and see whether any OC is there or not. And of course, if there's older children and mother complains there's a difficulty in swallowing and think of the social candidacies, then other features to be looked for from head to toe. Anemia, edema, and anemia again, you don't have to see the conjunctiva. Just see your palm. Just see the palm of the child and compare it to own palm, considering that your hemoglobin is normal. So if there are three classifications: no pallor, some pallor, severe pallor. That is the IMNCA classification, and that is called palmar pallor. So compare the baby's palm at how many seconds it will take. You just take the baby's palm and compare it to your own palm. If it's similar color, no pallor. If your palm is a bit reddish than the baby's palm, it's the some pallor. And the severe pallor, it's quite obvious. Mother will complain, my baby is pale. So it is very easy. Similarly, the edema, you will see in the press the dorsum of the foot and see if there's any dimple, and that is edema. And if in the dorsum, then you see the legs. It is in the picture, it is given the leg, that is +2, and in the whole body, the +3 edema is there. Signs of vitamin deficiency, already I said, glossitis, bitter spot, anglostomatitis, there will be chiliosis, and then there will be a crack in the lips and the angle of the mouth. Muscle wasting, clearly visible, and other features might be looked for. So it's very important just to run your eyes from head to toe and see the things. So what are the warning signs? Weight loss, sudden onset fatigue and loss of appetite, repeated vomiting or diarrhea, repeated episodes of fever, recurrent adherence issues, sudden fall in CD4 rising viral load, presence of new neurological signs like convulsion, regression of milestones, jaundice, or worsening of already present neurological, that is worsening of already present neurological signs. This is called regression of milestones. So you have to look, these are the warning signs that there's some problem is there. And don't hesitate to send the patient to the pediatrician if you are not able to diagnose these things. And it's very important, recurrent adherences. Why I said recurrent adherences, there may be some change in, there may be psychological issues, there may be mental issues, there may be physical issues, there may be other issues. So you have to check what are the issues, why babies adherence suddenly become problematic, or why it isn't having persistently even after counseling. What is the, where is the fault? So identify the fault and try to remove that. Use of reminders. So for adherence, you can take your own techniques, or you can take the help of these to increase the pill count, like pill counts, report by caregivers, refill boxes, checking pill charts and all. As I said, these all are the for our pseudo confidence the baby is having adherence. If you count the pill count, it may be good as per your calculation. Caregiver will give the good, yeah, baby is taking that. So if you refill boxes there, checking the pills, everything will give a pseudo confidence the baby is having good adherence. All these things not sufficient until always check the adherence and ask the child with the baby and ask the parents whether the baby has swallowed. Have you seen the swallowing of the tablet? And so sometimes what happens, if you take the give the tablet to the baby, we will take it in the mouth, they'll keep it for a long period. As soon as mother and father or whoever the caregiver is, they turn the head on the other side, they will spit it out. So make sure the baby has swallowed the tablet. That's very important. And after swallowing, you have to make sure that there's no vomiting within 15 to 20 minutes. At least if it's 30 minutes past, okay, it has gone to the stomach and there may be absorption procedure. So if see the 8-year-old girl on ALD has come for pill pickup, her weight is 22 kg. Father asked the doctor why her CD4 has fallen and viral load reported 10,000 kg. As per father, her grandmother is giving her pills regularly. On inquiring, the child revealed that she was taking 2.5 tablets pediatric AL60 twice a day. This is the what it is written here, and the similar the real scenario I have seen in the last session meeting. Similarly, So it's very important. You see, the 8-year is quite old. If you make them understand, they will understand the importance of taking the drug. His weight is 22 kg, means more or less good, because normal should have been near about 24 to 25 kg. And in between, we know the normal age 20% above and low is a normal range. So the weight is good. And you see, still there is a CD for low immunological failure, virological failure, 10,000. And grandmother's giving the pills. Now you see the chart. You just confirm the chart. 8 years, 8 years should have been 3 tablet of AL, 60-30. And grandmother's taking 2.5 tablets. What has happened and what steps should be taken to avoid this situation? So you have to count, you have to take the proper weight. You have to see your chart. See whether baby has taken the drug, age appropriate drug is taking or not, weight appropriate drug is taking or not. Then see the weight, then you calculate the tablets and see whether baby is taking or not, and emphasize it. You have to counsel the grandmother. When the grandmother is giving, you have to counsel the grandmother. If you counsel the father will go home and he will counsel the grandmother. So what will happen? The quality of counseling will be gradually deteriorated. As it passes from one person to other person, ultimately the target person will have a very poor quality of counseling. So you ask the caregiver who is going to take care of this kid and bring her to you, and you counsel directly to the grandmother. That will give a more emphasis for good follow. So they don't have to remember this. Just take the chart and keep it on table and see the table. So as the baby is 22 kg, is it in 22 kg? AL should have been 3 morning and 3 night. And baby was taking 2.5 tablets. So baby was taking low tablet. So there's a dose failure. Issue is wrong doses of AL. Dose 22 kg is 3 tablets twice a day. Hence viral suppression not present. When her weight had become 20 kg, the dose of 3 AL pediatric was increased to 3 tablet. But the increase in dose was not reinforced to the father or caregiver. Hence, ART was not effective in causing violence. So this is very important and very nicely written here. So you have to emphasize. Now, as I've said, that is the only, if you want to see one thing, you must please see the weight only. So weight is very important criteria, and then see the dose. And there are many staffs, many stations are there in the ART. And any one of you, please take the care of that. He will see the baby is taking the tablets as per his weight. So every minute, check the body weight. Drug doses have to be modified according to the change in weight, because there's a very fluctuant in case of younger days, more fluctuant the weight. So very important, each and every visit you have to calculate. Caregivers should be counseled. If you write it and you don't speak and don't counsel, don't make them understand what is the importance of increasing the dose, they will go on giving whatever they have received at the very beginning. Because at the very beginning, they were very receptive. At that time, they came to know their kids are positive. So they are very much in tension, and whatever you advise, they will very carefully listen and they'll follow. After that, they'll be immune. So it's very important to counsel the caregivers repeatedly. At every visit, counsel should speak to the child also. Medical affairs should reinforce the doses, and pharmacists should also reinforce the doses. So multiple stations, if it's re-emphasized, that will be good. Occurs usually after a period of, so as I said, fatigue. This occurs usually after a period of 2 years after the initiation of ART. Signs of adherence to fatigue in CLA. कितना दिन से खा रहे हैं और कितना दिन खाना पड़ेगा, ओ छोड़ दो, sort of, I am okay, I am feeling good, now I am having good. So they are totally fatigued of taking HIV. Changes in the confidence level and attitude to the treatment. Expression of feeling bad. Symptoms of psychological distress. Oh, long time I'm taking, how long I'll take the medicine. These are things called the adherence fatigue. Caregivers also feeling tired of looking after the child for the long time. And now in the maximum cases, the caregiver is the mother who is also positive. She is also having a sickness and problems. She has to take her own drug and has to do all the household chores or any job. So she feels tired of looking after the child. That's one of the issue might be there. Hence, repeated and continued counseling is necessary for children and caregivers to come over with the adherence fatigue. Okay. Now, what are the things we'll do and what time? There's a chart is there, and after what are the things you'll do at the very beginning when you'll start? What are the investigation you'll do according to the age and the drug indications of drug, like a pregnant adolescent girl sexually active, then you have to do the pregnancy test. In younger kids, you don't have to do that. So the age appropriate investigations and the drug, which drug you are going to do, or what treatment you have given as a OI. So any damage of any organ is there or not, so you have to know that is status. Then after 15 days, if you're zidovudine based, then you have to do the hemoglobin. After 1 month also, then 2 months also, at 3 months, then at 6 months. Usually we do 6 month interval when the patient is on tenofovir based drug or PI based drugs. So the baseline investigation. Others in directly biochemical test done on the availability such test. So these are the things not so important, but ALT based regime. If you see the SGOT and SGPT, there may be increase in SGOT 2 times and 3 times, but it's not pathognomony until unless it is more than 5 times of the normal limit. So it's very important to see how many times it has been increased, because AST and ALT may be increased because of the HIV, because of the concomitant infection, because of the malnutrition and all. But if it's more than 5 times, you must investigate the child cause of liver disease. And for liver functions and not only drug toxicity, what are the other diseases which can affect the liver, like Hep B, Hep C, is there or not? You have to check it. If you have checked already, and after that, even after 6 months, baby develops something, you might have to do the rechecking, reinvestigation can be done. For children with the PI-based or DTG-based drug, blood sugar, lipid profile, at the beginning and after 3 months and 6 months should be followed up. CD4, as we do, the percentage we do less than 5 years, because the total count is quite high as compared to adult. Respectively, some lymphocytes are quite high. So if you give the lymphocytes, so if you take the absolute value, CD4 will be quite high, but according to the age, it may be suppressed. So it's very important to take the ratio. Ratio is always constant. So if you take the ratio and multiply the 100, that is a percentage. So always we'll see the percentage below 5 years. And in adult or above 5 years, we follow the adult guideline. When CD4 is tested every 6 months, and when it's more than 350 and viral less than 1,000 copies, then we are not going to do regularly CD4 count monitoring. Pregnancy test advice, if an adolescent girl that too also sexually active, then only we go for the pregnancy test. Or even a baby is not, the child is not giving the exact data whether it's active or not, but you suspect there is some pregnancy might be there, you go for testing. As and when children develop signs and symptoms, TB, of course, then each and every visit you have to go for the testing. So there is another case. 6 months first line ART patient J has taken 6 months of ART, like a TLD. He underwent a viral load testing as taken September 2021. After 6 months, plasma viral report was targeted, not detected. That means has responded. Okay, let's see what happened thereafter. What will you explain to the patients and caregiver? ART's work. You can go on writing in the chat box. That will give a good things. So if you want to. So this is important. What will you explain to the patient and caregiver? Patient is taking a TLD for the 6 months. You don't know the age and weight is not given. So assume that as baby is on ART, TLD, that means baby is more than 10 years, more than 30 kg. And he underwent viral load testing the 2nd September 2021. It is target not detected. At that time, what will you do? That is working needs to be continued lifelong. And not only to say this, and you have to say you appreciate the child and the caregiver. Yeah, oh, well, you have done the wonderful job. You have taken the drug so nicely. And it is then must be very good. That's why you are so good and your viral load is not detected. You are suppressed. You are such a good boy. You suppress your virus by taking the drug. So you must appreciate the child along with the caregiver. The viral load report is undetectable, but the virus still present in patient's body. They might think, oh, it's not detected. That means it's gone out of my body. No, you make sure it is the machine who is not able to pick up. There might be some virus in the body, and there is a virus in the body, and which is not picked up because it's so low, so minimum that is not picked up is the machine. So you have to continue the drug lifelong, so that you can be having good quality of life and the virus be permanently suppressed. Counsel for 100% treatment adherence. So there's no point in satisfaction. Oh, your viral load is not TND, that means you're doing a good job. Don't leave it such. Again, counsel and make the treatment should be 100% throughout the life. And so you have to appreciate, you have to reinforce, and you have to re-counsel. It is now reciprocal. What will be the date of next viral load test? Anyone? So there's no time for next question. Next viral test will be after 6 months and after 12 months of VRT initiation. And due date, you have to mention, you have not only the write on the copy and green book, you have to utter it to the mouth. You have to say, next viral load is on the March 2022, after every year. So you have to counsel the parents. You don't write only because they are not going to read the book. No one read the whole prescription. So you ask them what is written, go thoroughly follow the prescription. Now, clinical scenario for viral load more than 1,000. So it is not suppressed. So what will you do? Either OI or maybe it's not taking properly, not taking the medicine properly, or there's a failure. If less than 1,000, so that means virus ART is working and continue the same regime. So in this case, again, you have to, when it's more than 1,000, why it is more than 1,000, what drug is given, what is the type of HIV infection, whether the route of taking the drug, whether they're taking syrup, or the form of taking drug, means tablet or syrup or pellets, what is he taking, then what is the dose. And as I already said, the compliance is very important. So before telling that there's a treatment failure or resistance. In case of less than 1,000, again, it's working, you appreciate the parents and caregivers and the child, and ask them to continue the good adherence. If it's not detectable, then does not mean the HIV has disappeared. You say it is not picked up by the machine. It is there, but it's suppressed. It's not able to make you sick. It is there. You have to emphasize the child that virus is there, but it's not so strong, not so in number that they won't make you sick. If you take the drug in that way, the virus will be sick and you will be okay, healthy. So keep on taking the drug daily, and 100% adherence must be maintained. Another case, the 12 years old ART for the last 3 years, he takes his pills daily. He never misses the dose. He under viral load test in 5th November 2021. Viral load test results was 10,000. What action will be taken by the staff at the ART center? So 3 years he is taking and no signs and symptoms, but at the routine viral testing, it has been shown that the virus load is 10,000. That means above the guideline, more than 1,000. So counsel will provide 3 sessions of special adherence counseling to the patient for 3 months. So you have to give extra energy. You have to give the extra time. And you have to counsel, step-up counseling to be done. And how to do the step-up counseling? There are some checkpoints. Make a checkpoints, make a questions, checklist, and ask them and do it regularly, every sessions. So 3 sessions must be taken. And sometimes you might need 4 sessions also. There's a guideline says at least 3 sessions, but you might need 4 sessions also, depending on the excuse me, depending upon the counselors, caregivers' acceptability and the understanding, their IQ level, their mental status, everything to be considered before counseling, and then only it will be successful. Check the doses of ARV drugs prescribed as per present weight. It's very important. In adolescent, there's a growth spurt. Suddenly they will get 2 to 3 kg. It's very important to check. They don't think, oh, he's already become 10 years adolescent, so there's no need to take the weight. No. Even adult also, we took regularly the weight. It's very important to take the weight and check the dose of the baby is taking as weight bed. Check whether the child is taking doses correctly or not. It's very important. Or any other issues are there. Disclosure is not done. So it is 12 years old, adolescent child, and if he does know what is happening, then it is won't continue. The adherence won't continue for a long time, and it won't be good for him also. So gradual disclosures to be done, and baby should have understood what the disease he is having and how to carry it on with the successful life. Master K has been provided 3 steps of counseling, and the repeat viral load is of 5,000 is still high. What will you do? What will the next action have taken at the ART center? Anyone? So, as you have done already 3 sessions for the adherence counseling, check it whether it is successful or not, check whether the child is taking doses correctly or not. These things again we are repeating every time. All have been excluded, then think of you have to refer this assay because you are thinking the baby may be in the failure, first line failure or second. So even a viral load disclosure in HIV, discrepancy between plasma viral load and CD4 cell recovery when CD4 does not increase despite viral load suppression. Sometimes you may happen. There is a low viral load, but CD4 is not increased. That's important. There may be discrepancy in the biological and immunological relation in the particular person, but you must suspect whether baby is suffering from any other opportunistic infections or not. Because HIV is taken care of. So there is a viral load is low, but CD4 is not increasing. Maybe there is some other infection which is suppressing the CD4 to rise. So it's very important to know the concomitant infection or co-infection. So recent viral infections, Hep B, Hep C, or drug-induced bone marrow suppression is there or not. Recent immunization and CD4 variability is very important. Possibility of HIV2 or HIV1 and 2 co-infections. Patient with immunological and viral discordance should be reviewed by the SASIF through ear referral. So these are the things you should do, but always take care because you have to follow the protocol. And if there's any discordance between the virology and immunology, you must send the patient to the SASIF. When to stop the CD4 monitoring? CD4 monitoring, the patients less than 5 years will go on seeing the percentage criteria. And it is more than 350, viral loads less than 1,000, baby is clinically well. Both is conducted same, should be done in the same time. If there is a 1 or 2 months gap, next scheduled time should be the same day. That will be easy for the patients and for calculation. CD4 monitoring should be restarted for any patient if the patient has suspected treatment failure. So CD4 monitoring when more than 350 for more 2 times, will stop doing the CD4 monitoring and the yearly viral load to be done. But when you will start, if you are thinking any symptoms, any new voice, any other complaint, or baby is not gaining weight, again you have to do the CD4 monitoring and you see whether the CD4 is low or not, and then suspected virological failure, clinical failure, or any switch regime is very important. Treating the doctors can replace CD4 or viral load test whenever clinically indicated. So protocol says this 6 months interval, then yearly interval. But in between, any time, any treating physician thinks there's a CD4 must be seen in this particular time, you must go for the CD4 testing or viral load testing. So this is again, we have already discussed, I'm not going in detail, that assessment, growth, perform physical examination, development, 4S, T staging is very important. Check adherence, calculate the ARD dose. We have already discussed finding with the caregiver, provide referrals as needed, advise and guide, schedule next visit. More than 2 years to 10 years of age, satisfy all the following criteria, will say the baby is in a stable age. Receiving ART for at least for 6 months, virologically suppressed, less than 1,000 copies per ml, should be on the same regime, not in changing regime for at least 3 months, should not have any active illness, medical condition that requires further management. And treatment adherence is more than 90, of course, more than 95% for at least 3 months, means more than 95%, then only will get the viral suppression sensitivity will be high. Width for is more than 2 SD, minus 2 SD, or height for length is more than minus 2 SD. Because less than minus 2 SD, 2 SD or more, it's not minus 2 SD, 2 SD, minus 2 SD or more. Less than minus 2 SD is the pathological condition. For children more than 10 years, when you say the baby is, child is stable, if on ART for 6 months, no adverse effect of ART, you are monitoring every month, no concurrent illness or opportunistic infection or any other medical conditions, suppressed viral load. In the absence of viral load monitoring, sometimes it's not possible or some kits not there, the viral load machine is not working, lots of issues might be there. At that time, you can follow with the rising CD4 count, which is increasing in trade. And in adult, we take children 10 years as an adult, so exceeding more than 200 cells per cubic millimeter, or adherence more than 95% consecutively over last 3 months. That's all those criteria have been fulfilled, we say the child is a stable child. So adverse effects, immediate, maybe immediate adverse effect, subacute adverse effect, or late adverse effect. And according to duration and according to the severity, we classify mild, moderate, severe, and seriously life-threatening. Mimics, there are sometimes there's a maybe confusion whether it is adverse effect or is a opportunistic infections. So what are the mimics? Opportunistic infections, like drug rash, maybe sometimes scabies also there, and there's a scabies, there are papillary eruptions and itchy, even drug rash, sometimes papillary eruptions will be there. So you will see that it is drug rash or the opportunistic infections. Common childhood diseases might be there because of the disease, or diarrhea, like suppose Avaka cause diarrhea, fever, and sometimes gastrointestinal infection, very common in pediatrics group, and that may cause diarrhea and fever. Complication of HIV infections, immune reconstitution, inflammatory syndrome, reaction to medication, other drugs. I'm not going to detail all those in details because that may be keep in mind that could be the differentials of your drug reactions. So another case, master 8 years old, started ALD 3 months back. That means he is more than 6 years, more than 20 kg. So 8 years ALD. He is asymptomatic at the time of initiation. CD4 was 144. Now child has developed high-grade fever, severe headache, nausea, projectile vomiting. He's been admitted in a civil hospital where it is investigated. Hemoglobin 11.5, CD4 320 is increased, and CSA positive for India patient. First, you see analyze the symptom. High-grade fever, that means infection. Where is the infection? The headache, nausea, and projectile vomiting. That means infection in the CNS. From the history only, it is very crucial and very judgmental in your clinical eyes or clinical knowledge. It's very easy to establish the diagnosis. So it's a high fever, headache, and vomiting. It is a CNS infection. What CNS infection? There are two possibilities. One is, as I said, the positive for India incubation, India incubation, cryptococcal. Or sometimes might not be there. India incubation not there. But CD4 has increased. So it may be iris. And the commonest iris we do get is the tuberculosis. There was a tuberculoma. It was asymptomatic. After starting care, there may be increase in the size or the number or the edema and leading to all the symptoms. So you have to keep in mind the iris. So one of the following can be most likely in this case: treatment failure, iris, drug adverse reaction, toxicity, or name of none of the above. Anyone? The answer is a B. Yes. Yes, very good. Iris. Someone has written iris, RPC. Very good. Correct answer. So always you see the signs and symptom and the localization and where it is. Make it anatomical localization and see the CD4 count. So CD4 is in. So there's immune reconstitution. It's giving the clue. Everything is there in the clue. In clicks, there is a clue in the child. So you have to search the clue and get it your answer from your questions. 6 years child, old master, I diagnosed HIV. His weight is 6 years, 20 kg. It's 20 kg, 6 years. That should have been 20 kg. It's 27 kg. Hemoglobin is low, 7.8 gram. He started ALD after baseline workup. On D6 of therapy, he developed fever, breathlessness, generalized as. What is the likely diagnosis? Anyone? So, Abacavir, you see? Fever, breathlessness, generalized rash. And we know the Abacavir is the most notorious for that. So it may be first, it may be due to something else, of course. Maybe it may be due to some other infections, but always think the dangerous thing and try to treat which is the life threatening. So Abacavir sensitivity is life threatening. Even if it is not Abacavir sensitivity, you consider it and treat like that. And if, of course, if it's not Abacavir sensitivity, you will get some clue. What should the immediate management? You have to stop all drugs, including ALD, give symptomatic management till the child recovers, preferably hospitalized patient. As I said, we have seen different varieties of Abacavir hypersensitivity or toxicity reactions. So if you are not confident enough and it is having like breathlessness, when there's a breathlessness, don't take this, don't ask them to go back home and come back after a few days stopping the. No, we get it admitted somewhere nearby hospitals and in your own hospital if facility is there. Does he require ART modifications or not? Of course. We never, so Abacavir should be permanently discontinued, never start the Abacavir again. So in this case, you have to refer the patient to the pCoE or SASEP for the next test. So hypersensitivity is a 35% in adult children, though it is less, but we have seen quite a few cases of hypersensitivity reaction in children. Monitor the hypersensitivity reaction. The first 6 weeks of course, is common in first 6 weeks, but it can happen in the 3 to 6 months. Risk of avacapillary hypersensitivity more in HLA-B 5701 alleles. So in the Western countries, they do check the HLA-B type 5701 allele, then they start avacapillary, but this is not there in our country. So we have to be based on the clinical eyes and clinical clues of the avacapillary hypersensitivity. Hypersensitivity reaction may behave like fever, constitutional symptoms, weight loss, lethargy, rash, GI symptoms like pain abdomen, diarrhea, respiratory symptoms such as breathlessness, tachypnea, pancreatitis with pain abdomen, severe organomegaly or fatty stool, steatosis, and laboratory radiological abnormalities might be there. So most common toxicity, I'm not going in detail. You all know the avacapillary hypersensitivity. But what is the rare? That is the we do get very rarely. That is DRESS syndrome. What is DRESS syndrome? There will be a hyper skin rash and all with eosinophilia. So if you think the rash is there and you go for the total eosinophilic count, TEC, total eosinophilic count, when there's an absolute eosinophilia with the rash, you can say this is maybe the DRESS syndrome. Then, of course, xyloidine-induced toxicity, again, it is a hematological toxicity, it's a more endangering the thing. So always see whether hemoglobin at a regular interval. Of course, always rule out other causes of anemia. Like we have our patient, a patient with anemia, severe anemia all the time. Every month he comes at the 4 gram hemoglobin. And we changed this drug and that drug and all. We thought it would be the drug and toxic. Lastly, we did the bone marrow and it was pure red cell aplasia along with HIV. So that might be the rare situation, but always look for the drug-induced bone marrow suppression. Then tenofovir, again, tenofovir, there are common, very nausea, diarrhea, vomiting, flatulence, or bone toxic, that is the bone mineral density. But we don't have machine below 8 years, at least in the government setup, we don't see the bone mineral density, sometimes not in the good hospitals also. We don't have a DEXA scan machine to know the bone mineral density, but at least you can see the vitamin D, calcium level, features of rickets and all, and can give the preventive therapy also sometimes. And rarely we do see it more in the older age group, the renal toxicity, Fanconi syndrome like symptoms like glycosuria, creatinine, high rise of creatinine, proteinuria, phosphaturia, and calcinuria. Sometimes there may be lactic acid with organomegaly with a fatty liver. And long exposure, maybe there's a obesity, that is a liver disease, obesity liver disease, that is the fatty liver disease. Renal and bone toxicity in growing children, adolescents remain a concern, especially in case of thalassemia. We do have some cases with thalassemia with regular blood transfusion with Hep B, Hep C, and HIV positive. There is very important. We should Jedobidin cannot give it because of the anemia, and there's a bone mineral density will be low in these children. And you have to, if you have to give the tenofovir, you have to take the support of calcium and vitamin D. Close monitoring and tenofovir toxicity is very important in adolescent children. Lopinavir again has some common side effects, which is very common with all the drugs like diarrhea, headache, vomiting, nausea. But in this lopinavir is notorious for doing the dyslipidemia, dyslipidemia, hyperlipidemia or dyslipidemia. Really, ECG problem like prolonged QR problems. So if there's any cardiac disorder, you have to do the ECG and all before starting the lopinavir. And sometimes you do have a hepatotoxicity. DTG, again, DTG, we didn't see much side effects, only a few cases of weight gain and hyperglycemia. Sometimes there's some few cases of insomnia and headache. And there may be possibility of hepatotoxicity neuropsychiatric disorder, but this adverse drug monitoring of DTG, we didn't get any such symptoms in our centers and rather all over India. So it's not that common, the symptoms. Only the weight gain and hyperglycemia few cases has been reported. So the sixth case, 13-year-old boy started ART TLD, and on day 6 therapy, he complains of drowsiness. What is the likely diagnosis? TLD, drowsiness. What will you think of? So as I said, in the DTG, there may be some drowsiness and insomnia and all. So you can think of, because tenofovir is not going to do the CNS problem, lopinavir is not going to do. So dolutegravir may be the cause. Does it require ART motivation? Yes. change the timing TTD. So timing of TLD as per convenience of the patient, self-limiting adverse, no need to change the ERT. So when drowsiness, when he is awake, he is roaming here and there in field. So you just take the evening time, and after that, just before sleeping, so that we may go off due to for 6 to 8 hours of sleep. Effeminase no more in the program. We are gradually taking off the effeminase based regimes, but effeminase is also notorious for the CNS toxicity in insomnia, dizziness, and other nightmares and all. Sometimes we have reported some cases of convulsion also. And of course, as other drugs, these drugs also cause hypersensitivity reaction, that rash in the skin. And few cases we have seen the gynecomastia may be there, but it's not that common. Neverpine, I'm not going to talk because it's no more in a program. The skin as neverpine is the most common incubated drug for rash. Any drug can cause rash. That is important. You don't have to mention any damn drug can cause the skin rash. So all the drugs, if you go through the rash, it is all the drugs can cause rash. So how do you manage? Rub the eye is very important. Exclude the iris. Grade the adverse reactions according to mild, moderate, severe. Keep symptomatic treatment. If life-threatening adverse drug reaction like Stevenson-Johnson syndrome or any other shock or like in evacuate hypersensitivity, immediately start the drug and you can refer the patient for admission. And you have to stabilize the patient. We should recover from the drug reactions, then only you start ERT. And it should be, I would rather say, especially in pediatrics group, when we are starting the ERT after recovery from the drug reaction, it should be supervised drug initiation. And if possible, it should be in the ward only after admission, as if taking care of the drug reactions, you are stabilizing the patient. After stabilization, start new regime or whatever the alternate regime or switchover, whatever you're going to do in the ward only. So it should be at least supervised for a few days, then you discharge the child. So you have to do the grading the severity of the drug rash, mild, moderate, severe, and potentially life-threatening. And the criteria, I'm not going to read all those criteria here. Yes. The skin rash also, if just keep in mind that if there's a vesiculation, the mucous membrane involvement, or any more than 30% of the body involvement, or there's any systemic signs, it is severe. You have to admit the patient, or sometimes you have to stop the drug. But grade 1, grade 2 may not have to stop the drug. So mild, avoid changing AT regime, offer symptomatic treatment, mild to moderate. But in severe and life-threatening, you have to change the drug. So you have to do the drug substitution, single drug replacement in the current ARV regime following adverse drug reactions or drug to drug, or not because of the failure. It is substitution. Switch indicates the entire regime change. Means it's because of the failure, or it is because of the drug problem of that particular drug. Single drug substitution for toxin should be made within the same ARV class. If a life-threatening adverse drug reaction occurs, stop all ARV drugs until the patient stabilizes. Thereafter, start the revised regime after taking sachet population. So any severity drug, if the more severe or life-threatening, you refer the patient to the sachet or pCoE or CoE, whatever. Children with a dual ARV toxicity should be preferably referred to pCoE. When there's not that severe, but a dual toxicity means, suppose there is skin rash with hypersensitivity or hepatotoxin and all, you always refer to the patient, the pCoE. TDF is advised in children more than 10 years and more than 30 kg, DTG more than 6 years and more than 20 kg. Abacavir, jadibudin, lopinavir is of no use for the have no age or weight criteria for use, but any age can be it can be used, but the below 6 years and below 20 kg, the first line will be abacavir, lopinavir, ritonavir, AAL, LPVR will be the first line of treatment. And of course, dose always according to the weight. Not going in detail, these are the alternate substances. I'm not going in detail. Abacavir hypersensitivity or not, then you can give the jadibudin, of course, if hemoglobin is good. If hemoglobin is low, then tenofovir. If the baby is not eligible for tenofovir, then it's difficult. The person is less than 10, then it's very difficult to give abacavir, cannot give jadibudin, then DTG and lopinavir may be the rare options. If jadibudin, then less than 10 years, you can go up to abacavir, and more than 10 years, you can go to switch over to the one drug. You can have to substitute from jadibudin to tenofovir due to the drug toxicity. Again, here also substitution when the lopinavir more than 6 years, more than 20, you can go directly to DTG, but below 6 years, below 20, but above 3 years, because you cannot use epiphanies below 3 years. So epiphanies will be there. And less than 3 years, again, I have to give the nevirapine-based drug. In case of epiphanies toxicity, though it's not more in everywhere, the epiphany is gradually withdrawing from the program, so there's no more cases. You might not get this type of disease. Is more than 6 years, body weight more than 20 kg, and there's a epiphany toxicity, directly go for DTG. But where you cannot give the DTG because of age is less than 6 years, less than 20, go for the lopinavir. And where in case of nevirapine, again, you follow the same chart, either DTG or lopinavir, according to the weight and age criteria. So, I already said this, I'm not going in detail again. There's a repetition, transition, and virally suppressed. So, if you want to transition of the drugs in virally suppressed, you have to see the viral load. So, whenever you want to change the drug, you have to see the viral load and virally suppressed. Then, if JDL and ALN is there, go with the ALLPBR. But it was the more than 20, 30 in ALD. Directly, where you the first preference is a TLD. If not eligible for tenofovir, then go the next preferred drug with the ALD. If again the dolutegravir is not appropriate for the AL, then go for the ALPVR. Drug doses, I'm not going in detail. You just have a chart and see according to the drug doses. So what are the key points of my presentations? ARV-related adverse events may overlap with the HIV-associated conditions, not only HIV, rather also opportunistic infections. And that may be due to organ dysfunction, opportunistic infections, iris, other common childhood disease, or similar side effects of the concomitant medications. Sometimes drug may be the cause, as it's written, concomitant medication. So there's a hepatotoxicity, maybe due to HIV, maybe Hep B, Hep C, maybe tuberculosis, maybe the any drug. Differentiating ARV-related adverse events from these conditions pose a great challenge. So always, there's no harm in taking the second opinion. If you are in confusion, take the opinion from the others. So always be confident about the differentiating the ARV-related adverse event from the opportunistic or disease itself. Most common ARV-related side effects are self-limiting and resolve on continued ARVs with a simple supportive measures, if mild to moderate. Adverse events are most important barriers for optimal adherence. So if we see some cases, and especially in pediatric younger age, they say bitter taste, nauseating. Whenever I take the drug, I feel nauseating. So what will they do? They will stop taking without telling anyone. They'll say, I'm taking the medication, but because of the nausea and vomiting, they won't take. So that is the most important issue of non-compliance. So adverse events is very important. It's a barrier for important barrier, the strong barrier for the optimal adherence. Proactive approach is required to limit the non-adherence. I have said in the very beginning, a proper counseling of understanding the child and caregiver before initiation of ART is very utmost important. So counseling, the ultimatum of everything. In a medical science, we say 90% counseling and 10% medication works in any disease. Similarly here also. Thank you. Oh, next. Thank you for your patience, Annie. If you have any queries, I would love to answer.
Thank you so much, ma'am. Are there any questions? Participants can unmute their mic or even put questions in the chat box.
So
Ma'am, I don't think there are any questions.
Okay, I will stop sharing, huh?
Yes, yes, ma'am. Thank you so much, ma'am, for facilitating this session. All the participants are requested to please attempt the feedback poll. The questions are now visible on your screen. There are 4 questions in all. Please scroll through all the 4 questions and answer them. The next topic is ART treatment failure in children. We are yet to decide on the date for the session, so I'll announce it later. But for this chapter, you can refer to chapter number 3.5 of the National Guidelines for ART care and treatment. Requesting all the participants to please attempt the feedback poll. Thank you so much to all the participants for patient listening. Ma'am, can we conclude this session now?
Yes, thank
Thank
you
you
all.
so much,
Thank
ma'am.
you.
Thank you.
Thank you.